Good morning and welcome everyone. My name is Eric Glazer. You have dialed into the Population Health Executive Roundtable, where we're going to be talking about reinventing consumer engagement in chronic care. We have a ton to cover, so I'm going to rush through the formalities this morning. My company, Shared Purpose Connect, we produce online courses for population health leaders, as well as over the last 4 years, typically on the fourth Thursday of the month, host this roundtable for healthcare leaders around the country. And our whole goal is to bring together people who are doing some great things successfully, whether it be in technology or within a clinical process or over at a health plan. And the objective here is we just believe if more folks shared their bright spots at their organizations, and we were able to have all of you who are listening and dialing in to be inspired by those ideas and maybe copy and clone them and bring them to your organization, we could help more consumers, more Americans in and around their health with better outcomes, and hopefully help in the economics of our businesses around the country who work in healthcare. So I don't think there's a topic that illustrates this better than consumer engagement and chronic illness. I have spent a lot of time reading, researching, and looking at some of the successes that organizations like Alcoholics Anonymous and Weight Watchers have had, putting together and leveraging the social relationships that drive actually impactful engagement and improve outcomes for those suffering from chronic illnesses. And thus, we have put together this all-star panel. It's made up of 3 inspiring and brave patient leaders and 3 forward-thinking, innovative physician leaders to share some stories and explore ideas around how they are applying these principles of peer mentoring into other areas in healthcare and other chronic illnesses. Now, we did this topic really successfully in July. Why are we doing it again so soon after? Well, it's because you asked for it. And you asked for this topic to be repeated through the feedback survey that we send out towards the top of the hour. And I mentioned that because if you want to get less emails from me, and I'm sure you do, please, towards the top of the hour, check your email and take the 2.5 minutes it takes to fill out that multiple choice feedback form. Our team, we have a team of 4 that produces these events. We put a lot of time into it, and it's a labor of love. But we want to make sure, if we're doing these events, that they really are valuable and time well spent for all of you, because we know you're super busy. And so it is important that these surveys are completed so we know exactly where to go with our programming throughout the rest of the year. So that's my big sort of infomercial. Please take that survey if you can. Final thing, disclaimer. Although I love doing this and we do a lot of things around shared purpose, I actually have a day job that's not Shared Purpose Connect, and it's running product innovation for the largest virtual care provider in the country. That company is called Teladoc Health. This event is not sponsored by Teladoc Health. It's not funded in any way. It's not affiliated in any way. I'm speaking today as the leader of Shared Purpose Connect and your moderator of the roundtable. Okay. Without further ado, I'm going to introduce to you now half of our panel. I'm going to introduce to you our patient leaders first. Then we're going to throw out the first question and get our discussion going. And then I'll bring in our physician leaders right before we get started. So I'm going to pull up my notes here. Our first illustrious panelist is Julie Croner. She describes herself as a patient empowerer. Her official title is patient leader and network director at WeGo Health. They're a incredibly interesting, exciting company, very mission driven. They connect healthcare organizations with the insights and advocacy of a network of over 100,000 patient leaders from around the country. They are not a sponsor. None of these panelists represent sponsoring companies, by the way. If I'm endorsing any links or any work that our panelists are doing, it's just because I think they're valuable for all of us to take a look at. Julie's online. Her blogs, It's Just a Bad Day. It's Just a Bad Day, Not a Bad Life, and you can check out that blog at itsjustabadday.com. So Julie, thanks for joining us. I'm going to come back to you in a moment with our first question. Our next panelist is Lisa Davis-Budzinski. If I got that right, Lisa. Lisa is Lisa was in the legal profession for over 20 years and then had a stroke and a diagnosis of thyroid cancer. And she decided that she needed to leave her legal career and find a way to help others with her ailment and help them through their healthcare journey. So she founded something called the Central Pain Nervous Center, and you can check them out at centralpainnervecenter.com. And that is designed to help fellow patients with central pain syndrome and other intractable pain illnesses or conditions through research, education, mentoring, and advocacy. And you could also on Amazon still, I think, find her book At the End of the Day. So if you type in At the End of the Day on Amazon, you could check out Lisa's book. Our next panelist is Daniel Garza. He is an actor, he's a speaker, he's an HIV advocate. He was diagnosed in 2000, became sort of a full-time advocate in 2001. He started by educating first his family and then the Latino community. He's the chair of the Laguna Beach HIV Advisory Council. He's also a drug and alcohol counselor and an outreach ambassador for the University of California, Irvine. And if that's not enough, he hosts a regular podcast that you could find on any of your Android applications or on iTunes called Put It Together. And there he brings together people from different backgrounds and learns and has them tell about their journeys through health, recovery, and life. So check that out. So thank you, all three of you, for joining us. I'm going to start by setting the stage. I want to define sort of what peer mentoring means and means to you. So Julie, I'm going to have you take that question first, get us rolling before we introduce our physician leaders.
Sure. So peer mentoring is something that I don't think I ever really gave much thought to. So my story, at least my health journey in peer mentoring starts, I graduated college and was working what I thought was my dream job at Deloitte Consulting, run around the country, helping companies integrate their IT systems. But 5 years into my career, I ended up on disability. A disability stint that would end up being about 4 years long for a myriad of reasons: psoriatic arthritis, avascular necrosis, complex regional pain syndrome, melanoma, anxiety, depression. It was just a lot. I got to tell you, when I think back on that time, it's not in a lovingly way. It was definitely the darkest point in my life. And after being bedridden for 6 months and not being able to walk, I just remember crying to my parents thinking, I've lost everything. I've lost my job. I've lost a lot of my friends. I lost the boyfriend that I had at the time. I lost my independence because I had to move back in with them because I couldn't function on my own. They couldn't understand what I was going through. And I'm glad that they couldn't, because I didn't believe that they could understand unless they actually had what I had. So I'm going to focus on one part of my journey, the avascular necrosis, although I've used peer mentoring within every diagnosis that I've had. But with the AVN, December 12th, 2012, I will always remember that day. I walked into my doctor's appointment after spending months in so much pain, not being able to walk on my left leg. And he is a very prominent orthopedic surgeon here in Pittsburgh. So I had already gotten 5 knee surgeries over the course of many years with him. He was a very trusted source in my life. And he looked at me and he said, "Julie, you have avascular necrosis. I know what it is. I see it before, but I don't know how to treat you. And I don't even know where to send you. I'm a pretty positive person, but someone who I really trusted didn't even know where to send me." So from that point on, I went home and I cried for, I think, the next week, thinking, what am I going to do? My bone is dead in 2 places in my leg. My top doctor doesn't even know what to do with me. So I started talking to family and friends. I lost count at over 29 health providers that I went to. And I'm not talking about small health providers. I mean, I went to the top doctors, walking in so full of hope and then walking out crushed because they would say the same thing. I know what it is. I've seen it before. I don't know the best way to treat it. The best advice that I got was to walk on crutches for 10 years until my knee completely collapsed and then get a knee replacement. I was mid-20s. That was not acceptable to me. So I had always loved social media. So I turned to Google and I started searching, are there other patients talking about this? Are there blogs? Are there social channels out there? And I started connecting with other people who were in the same shoes as me. They had this horrible, crippling pain. They were living on opioids. They couldn't walk. One person I started talking to said, go to my doctor in Cincinnati. He's, doing these treatments. So we packed up, drove 5 hours. We went there, and that started to help me. But really what got me on the path to healing was I found this whole community talking about stem cell procedures done within, for avascular necrosis. They weren't just talking about it. They were talking about what questions to ask your doctor, what to look out for, to just don't walk into any clinic and get stem cells. They were also sharing MRI films to show progression of like, hey, this is actually working for me. And over the course of several months, I started building relationships with these people to the point where I was talking to them on the phone. One woman wasn't able to walk. Then she ended up teaching yoga and taking people on hiking trips in Costa Rica. So I thought, this is what I need to be doing. So that's really talking to other patients. I started talking to my doctors about this. I ended up going to a different clinic. I got the stem cell procedure done for myself. In March, it'll be 4 years. Not only did I get my life back, but I became a yoga instructor. I live an active life. I was able to get married and walk down the aisle, which is something I wasn't sure I was even going to be able to walk again. I was able to have a baby, and the added weight of pregnancy didn't crush my knee. So I wish I could say that these top doctors that I really, really trusted helped me get me there, but it wasn't. It was the patients online talking about their own experiences is really what helped me find providers that got me healing. They believed in me, and they believed in my healing process.
Wow. So I'm gonna pause there. I'm gonna bring in our physicians now to react to some of that. And so we've got a great team, as I mentioned earlier, of 3 physicians on today's call around the roundtable. In alphabetical order, Dr. Julie Day has over 30 years experience as a primary care doctor. She is presently the Medical Director of Quality Improvement and Population Health Management at the University of Utah Community Physicians Group, where she oversees CQI activities for 11 clinics around the region. She will be in on audio only. We have Dr. Ramiro Jervis down in New York City. He is a practicing internist at NYU Langone Health. He's also a clinical associate professor at NYU. He's done a lot of research and publications in the Journal of Internal Medicine. Most recently, his article, A Novel Multidisciplinary Primary Care Program to Improve Care and Outcomes for utilizers. And last but certainly not least is Dr. Marianne Sumego. She is a dual certified in internal medicine and pediatrics. She works at a little-known organization called the Cleveland Clinic, where she's the director of shared medical appointments. She implements and has executed over 300 shared medical appointments, and also works with health systems both nationally and internationally to help them develop shared medical appointments throughout this beautiful world of ours. So thank you, the 3 of us, for also joining us. I'm going to bring in Dr. Julie Day first. Julie, what are the best ways to improve the patient experience and establish better trust between patient and provider, especially in light of what you heard Julie Croner say?
That was such an impressive story about reaching out to a broader community. In our work, we have tried to figure out with our delivery of healthcare, how can we address the issues around having patients have some kind of a shared experience? How can we tap into mentoring each other within our clinics? And so what we have done some work around is shared medical appointments, where we will bring patients into a group setting and have a standard medical appointment, but doing that in the presence of others. So what that looks like is obviously the patients sign a release to have their information shared, but we share lab data, lab information, and the provider or clinician doing the work does physical exam right in the room, very brief, while someone else is moderating a discussion around a topic. We have done this mostly, our most common disease entity has been around diabetes and the struggles that people have with managing that as a chronic disease. So I love to tell the story about, it was actually the very first one of these I attended was done in Spanish. And we had family members that were attending with the patients. And what was most impressive to me was we had great discussion going on about the diabetes and management. And behind all of this, our goal is really to get into some kind of self-efficacy and how we help patients really manage when we're not there, certainly 98% of the time. But at the end of our first visit, one of the patients spontaneously stood up and addressed the whole group and said, really the key here is we have to drive this ourselves. We're responsible for managing our own diabetes. We can't rely on our husband. We can't rely on our friends. It's up to us to be checking our blood sugars and owning this process. And hearing that from one of the peers made all the difference in that group. It's so different when you hear it from a peer as opposed to hearing your physician encouraging you to do that kind of thing. So that's one of the ways of addressing sort of the isolation that we have addressed within our clinics.
Eric, I think you're on mute.
I told you guys that was going to happen, right? I was going to say, let's stick with shared appointments for a moment. And I'm going to bring in Dr. Marianne Sumego, who I think now over 8 years has been in charge of the shared appointment program at Cleveland Clinic. Can you tell us a little bit about sort of how peer mentoring works within your program at Cleveland?
Yeah, of course. So to be honest, I started shared medical appointments back in 1999. So I've been doing them for close to 20 years, and I started them just as a provider. I felt the need to do more in a visit. It was becoming a checklist, and it just felt like the ability to develop that relationship and fully understand the needs was something I was already struggling with. And so after hearing Ed Nofsinger, we started doing shared medical appointments. For the past 10 years, we've been doing them in an organized fashion. And so, one of the things that I often talk about is we started them before all of the concerns of access and cost. And we started them because it was a patient-driven, patient-centered appointment. And so one of my roles is to develop all of the shared medical appointments. So I have the wonderful advantage of seeing a lot of the positive encounters. And for us, peer mentoring is the presence of peers. I mean, it's as simple as that. So it's a series of appointments with everyone observing each other, and they have full value and full access to someone else's story, someone else's tips, someone else's lifestyle needs. And there's times when I've done a wellness and I had a patient who did not want to pursue their follow-up screening because they had an adenoma. They were really nervous about it. They didn't like their experience. And in the group, we talked about it. And this other gal spoke up and said, I had my colonoscopy. They found cancer. You need to have yours. And so I had been ordering that test because I'm a good physician, right? And advising it because I have the right terms. and the presence of that other patient had so much impact. That's something that we miss in our day-to-day. Same with diabetes. Just another quick example of leveraging the peer mentor. Have gentlemen, and I was observing one of my providers doing the shared medical appointment. He works third shift. He really had trouble fitting in his diet. His boss wasn't giving him time off. He was missing snacks. And there was about 8 other folks in his room, and they spoke up. They spoke up and said, you need your breaks at work. You need to be able to manage your diabetes, and it's more important than your job. But the other thing that they did, which is something that's more important, is the doctor who was managing this was great. She knew everything about diabetes, but she didn't have diabetes. And so that's one of the peer mentoring values that I think is really significant. The person telling this gentleman how to fix his meals or how to manage that break with his diabetes was really powerful. And so it's my doctor knows how to do diabetes, but they don't have it. They're not in my shoes. And that's something that other people bring to the table. And certainly we can talk more about it, but mentoring is really using the presence of other folks to impact the details, the barriers, the challenges, and the understanding of that disease. And so we've really expanded our concept beyond that for those reasons. And that's been a driver for us.
Oh, it's great. Those of you in the audience, I forgot to mention, if you have follow-up questions to what you're hearing today, there is a Q&A module towards the bottom of your screen. As time permits, I could try to get some of your questions integrated in our conversation here today. And if we can't get them today, maybe I could follow up through email and try to get answers for you. So with that stage set, why don't we bring in, Lisa, why don't we bring in your perspective with your patient hat on and talk to me about what you think makes a peer support program achieve success?
I think that when you have patients that are in desperate need, you have to provide some type of hope and inspiration. By the time that we see other patients or speak with them, whether in face or online, they're in a desperate position. Like Julie was mentioning, you give up all hope, you've been everywhere. You have to let them know that, yes, I've been there. This is what can happen. We can support you, and these things do work. So you have to give them some type of hope back.
Okay. And as far, from a physician perspective, Dr. Julie Day, what do you think, what's your perspective on that? How do you make sure that these programs are achieving positive results?
One of the other programs that we've had a lot of success with has been a program that was developed by Kate Lorig out of Stanford. It's called Living Well with Chronic Disease. And in terms of what makes that work, I think it is a very structured program. But I think the success lies in recognizing that when people have one chronic disease or a number of comorbidities, other chronic diseases that they're dealing with, it just feels so big. It feels like such a monstrous sort of thing to tackle that I think what helps them is being able to break that down into smaller components so that you can really set really small, manageable goals with the patients. There was one of our patients talked about, I'm going to try and eat breakfast most days of the week. And then when he came back, he said, oh, I'm going to try to eat breakfast at this time of day. And then he did that kind of thing with exercise and folding that into a lot of other life skills. So I think a lot of that tends to be certainly the peer support and the encouragement from peers. We had another group that was very cohesive, and when one of the members was put into a skilled nursing facility, two of the women became so friendly that they were going to visit, and they were supporting each other in these types of smaller goals that they were working on. So there was a lot of mutual encouragement and support through the cohesiveness of this group. But breaking it down into these smaller bite-sized pieces, I think, is really key for patients and giving them the skills to think about it in smaller bites.
Marianne, is there anything different at Cleveland Clinic that you guys are doing to sort of drive positive results, make sure that you're achieving those results?
We actually ask our patients. So one of the things that we do after every appointment is we ask patients what their experience was to get what they needed. And that's one of the methods that we've been able to see how to develop the shared medical appointment in a fashion that's effective for the patients, that promotes the interactions that they need, and also exposes them to the information that's most important. So I think that's patients will tell you what they need, and sometimes it's taking the time to ask. And so that's something that we value, and one of the ways that we're really monitoring how we develop these.
So let's get in now to like the one-on-one relationship to the patient sort of in distress and struggling and the mentor themselves. I'm going to bring in Daniel Garza with the sort of his mentor hat on. Daniel, what approaches do you take to make sure that folks that you're working with and have all these challenges, how do you help them deal with it and overcome them?
Well, first of all, hi, everybody. Thank you for including me in this great panel. I'm learning a lot. There are some things that I didn't know, so this is really cool.
Awesome.
One of the first things that I went through when I was first diagnosed was I had people around me at the clinic who included me in some of the events. Rather than just giving me, well, this is back in 2000 before we really had a lot of websites to go to or a lot of information to go to. There was all these pamphlets that they would give you to read, and I really wasn't in the mood to read anything. So one of the first things was being inclusive. There were luncheons, there were outings, there were field trips that they would do, and I was being invited to join in those, so that I could see how other people living with HIV were doing day-to-day things, or people who were on disability were keeping a healthy and active life. So I learned from that, and that's what I try to do as much as I can. I live in Laguna Beach. I work also in Los Angeles. Everybody's always busy, but we make a time for at least some lunch time where I can listen to the person that I'm mentoring or peer counseling. I need to know first what their condition is, social, religious, cultural, etc., before I can start giving them advice or suggestions, because what works for me is not going to always work for them. I really do believe that we learn a lot more by doing than by talking sometimes, especially when you're in the condition and all you see around you is pain or hurt or isolation. I think we need somebody to go in there and kind of pull you out a little bit and go, there's more beyond HIV, diabetes, cancer, kind of like come and join the real world again. That's my take as much as I can. And again, I know people are probably listening going, really? Well, you do it as much as you can and you help as much as you can. And not everybody's open to it, but those that are, I like to do that with them.
And Lisa, I know when we spoke in preparation for this, you were telling me a story about one of your, I guess we'll call them your clients. I don't know if you officially call them clients. Tom, I mean, so how does, take me through how you're working with those challenges and getting folks sort of on the right path.
It's the basis of what Daniel was just saying, that it's a dark place when you have comorbidities or you run out of hope. And we have to establish, as a patient mentor, some credibility. We have to relate to, I've been there, I've done that, I can help you, I know what you're talking about, I felt that way myself. And Tom was at the brink of suicide, of giving up. I've tried all I could, I don't want to live anymore in this type of intractable pain. And it takes a person knowing the credibility for relatability, or relatability for the credibility. Him knowing that I had been there for over 12 years and I've gone through the same thing, give him hope. And you have to have that hope and positivity to help them get out of that dark hole and become part of life again, because there is life after such darkness, and it can be attained.
That's great. I'm going to, and get ready, Daniel, I'm going to shoot back to you in a second, but I want to bring in Dr. Ramiro Jervis into the conversation. I know I see some people submitted some questions. There's a Q&A module, if you didn't hear me mention it earlier, at the bottom of your screen to ask follow-up questions to Lisa and everyone else who's making these really nice and astute comments. And I know, George, I'm going to hold off on your question that you just submitted for about 5 minutes. I'm going to place it, I think, in a nice part of our conversation. So I got your back here, but I'm going to hang on for a second. So Dr. Ramiro Jervis, I want to talk about how mentors can potentially improve the primary care experience. And then Daniel, I'm going to shift it back over to you, and we're going to go into some of the things we talked about the other day about how you prepare your folks that you're advocating for and mentoring for their doctor's appointments. So Ramiro, why don't you step up?
So at NYU Langone, we have community health workers who fill in that role as peers, and they're very helpful in sort of bridging that communication divide between physicians and patients. So in terms of improving that primary care experience, physicians usually only have 15 minutes, maybe 30 minutes in a good day to spend time with patients. And our most complex patients don't really have, will be quick to say, yes, they understand the instructions, but in between appointments, which can be as far apart as 3 months, often those goals that are made within that appointment aren't often lived up to. But the community health workers can meet patients in the home and reinforce that message. In the best situations, they'll actually be in the appointments listening to the physician's instructions and then help reinforce that with the patient after the appointment. And that is value added to both the physicians and the patients. The patients appreciate it, and the patients also appreciate someone who has time to listen to their issues and their challenges. A good mentor also helps communicate those challenges to the physician so we can tailor the regimen to meet the patient's needs. I have a patient who I prescribed an insulin regimen which seemed appropriate, Lantus plus 3 times a day short-acting insulin, and the patient couldn't adhere to it. They weren't really sharing with me why they couldn't adhere to it because of their financial issues, and they had some dexterity issues with their hands in giving themselves insulin. So a community health worker or a peer can help communicate those challenges to the physician so we can change the regimen to actually meet their needs.
So Daniel, I mean, that tees you up very nicely, right? Because it's sort of right on line with what we were talking about the other day. So can you talk a little bit about how you see sort of your role in helping folks get ready for their doctor's appointment and make their experience better?
Yeah. One of the things that I like doing with peers is going over their questions. Sometimes it, like Doctor was saying, it's beyond just the medical regimen. It's I go back, cultural, religious, financial, job, children. There's all these factors that can influence how you take care of yourself during the day. And from my experience, sometimes we don't say that to doctors to not sound like an excuse for not wanting to follow a regimen. So when we're able to talk to each other and people can tell me this is what the situation is, then I can be the buffer to the doctor and say, look, here's the actual situation. They don't want to sound like whiners, so I'm going to translate for you what the situation is. And that definitely helps. But one of the most important things that I always tell my peers is have your questions ready. It sounds like such a simple thing to write down your questions before an appointment, but I'll be honest, sometimes I forget myself. But once you walk in with that level of preparedness, it shows, I think, the doctor that you're ready and willing to take care of your issues. Plus, it gives you that empowerment that you need as a patient to know that you're working with the doctor. You're not just there for a visit. You're working on your situation together.
That's great. I'm gonna share same question. I'm gonna talk about how mentors can improve the primary care experience, but I'm gonna bring in Dr. Marianne Sumego. And Marianne, I'm gonna ask you, how does it improve your experience as the physician? How can mentoring improve your experience as a physician?
So, as a provider, we go into medicine because we want to take care of patients and we want to teach and we want to do it well. And so I'm going to from the setting of the shared medical appointments because that's really where peer mentoring and practice intersect for us. And so when I'm in a shared medical appointment and I'm watching other patients interact, bring up questions that someone forgot to ask, like Daniel said, they have their list. I feel like I'm covering more ground. I see 10 people with diabetes, I'm saying the same thing, and each person's hearing it differently and separately, and that ability to expand on it or to get more into their personal experience, their barriers, isn't there. And so when I'm in a shared appointment, and there's 10 folks there that hear what diabetes is, or what about your nutrition and your weight loss and your hypertension. Now I can get to the second sentence and the third sentence. I can ask them where they shop, who they're eating with. And when I can do that, the relationship develops. I feel like I've done more, offered more. Personally, it's more satisfying. Our feedback from providers is it breaks up my day. It's a different appointment. We love it. It's something where we feel like we're really working with the patients. We're watching the patients intervene with each other. And, the other thing is patients teach us too. So, I was listening to Dr. Jervis, and I've done the same thing. I've said, here, I'm going to start you on an injectable. And the lady didn't know how to use it. And so I changed my approach to understanding what the barriers were, what the hesitations would be, based on her feedback. And it was something that may not come up in a different setting. And so it made me feel like I was doing as much as I could for the patients and as a provider. And to be honest, that's the driver of my day. So if we want to talk about physician burnout, and patient interactions and engagement, they are so tied together. And so looking for ways of expanding on that care delivery, doing it so that it benefits the patients and it benefits the providers, it's kind of like a win-win. So from my perspective, that's something that the shared appointments have really added for me.
Yeah, it's powerful. That's powerful. Let me bring, there's a question from the audience. So fair warning, we didn't prep for this, guys. I'm going to ask this to our physicians. So Dr. Matthew asks, as a doctor without a condition, but wanting to be supportive of peer mentoring programs, how do I promote these types of programs effectively? Does anyone want to jump in and take that?
So, I'm going to jump in real quick because that's actually the whole point of shared medical appointments. I may have a great doctor, and we talked about Cheryl's story, which I can share later. She had seen endo and a lot of folks for her diabetes care, great doctors, but they didn't have diabetes, that role modeling, that lifestyle experience, that expectation. And so when she went into the shared medical appointments, the positive impact that she had was unrelated to whether the doctor had a condition. It was related to the patients and their experience and walking in their shoes. If you have high blood pressure or migraines, certainly as a physician, you're going to add that empathy into your experience with taking care of patients. But I don't have every condition. And that's the whole point of encouraging patients in that shared model. And so to Dr. Matthew, that's why I do it. The patient talked about insulin because she was a person who already used it, had started it, and could advise that other patient there, and really changed the way I did it and made me a better provider. So I'm sure there's other ways of bringing community resources in that our colleagues can talk about as well, but that's one of the simplest ways of doing what you're doing, and just doing it a little bit differently and empowering the patient rather than you being the sole owner of the experience and all of the recommendations.
So to help George kind of market this, his organization, it sounds like cost-effective way of making you as a doctor be smarter and enable you to be able to help more patients more effectively. Something
Absolutely.
like that?
Yeah, I mean, if you were to ask our patients right now, they would tell you what we're doing isn't working. We can't just go do a checklist of health maintenance and medications and refills, and then on that list also address why the patient's there and take the additional time. So we have to not work harder, we have to work smarter. And so I think that every one of them would suggest that they walk out of an appointment thinking of a question they didn't ask, or too much information, or maybe they took one piece of information because that's all they were ready to listen to. And this really neutralizes all of that. So I have a bias after 20 years, but I wouldn't still be doing it after 20 years
Sure.
either if I didn't see that benefit. So yes, cost, patient, provider. For me, it is a work smarter and have more fun model.
I just want to circle back for a minute. This is Dr. Day too. I love shared medical appointments, but I want to maybe circle back to our Living Well with Chronic Disease program. And that is designed to be this exact type of peer mentoring. And one of the things that we have done just to connect that, because it is not done by the provider, so it is a little bit of outside of clinic flow. But one of the sort of interesting techniques we have used is at the end of these sessions that the patients go through, and there are 8 sessions that they go through. We've asked the patients to write a little note saying what they would tell their primary care provider they've learned from the session, and encourage them to actually share that with the primary care provider. So it loops it back into the clinical practice. And the feedback that we have had is things like, this is the best program you could have referred me to. I've learned so much. One of our chronic disease patients said, this program saved my life. So there is that connecting it back into the clinic piece that's important as well.
Let's move to economics a bit, because it's been alluded to a little bit, and I know we're talking a lot about shared appointments, but I'll broaden the question on how a mentoring program could actually impact the economics of chronic care. So Julie, I'm gonna start with you.
So,
sorry, Julie Croner. My bad. Yeah.
So I do not work for a health plan or anything like that, but when I look at my situation with my AVN, I think in terms of numbers, if you look at so let's just do a little bit of math here, which I'm horrible at math, but keep me honest here, Eric. The best solution I had been given by a provider was to get a knee replacement, okay? So say I would have got a knee replacement. In different markets, it's a different price. I like to call it, let's just say 40,000, because that's a good average. So it would have been 40,000 for the procedure. That's not really taking into account time off from work, personal expenses, physical therapy, and that's if everything goes smoothly, right? And I know a lot of people that it doesn't go smoothly. I was in my 20s. So let's be honest here. I would have had to have at least gotten 2 more knee surgeries by the time I left this earth, God willing. So right there, that's a substantial amount of money that I would have been causing my health plan to cover, because I'm not going to be paying out of pocket. Now, for the stem cell procedure that I had done, I paid out of pocket all in, I think it was about $12,000. So if you look at $12,000 versus, let's just say 1 knee replacement, $40,000. I mean,
28 grand minimum.
Yeah, right.
Probably more than that. Yeah.
So
you health plans out there listening, take note of that.
Right. I know. So it's like, I got my health back, I got my life back, and I saved them all this money. Where's my check?
Yeah, that's right. All right. Well, let's bring in a provider like Marianne. What's your take on that? Like, how does a mentoring program impact sort of the economics here?
I think that the summary statement that we know that a better managed patient in the long run is going to lower the cost of managing any chronic disease kind of says it all. And if we can leverage patients as well as physician knowledge in the same appointment, we have shown, we have an asthma shared appointment, and folks were having their action plans done, and they were aware of their triggers, and they were appropriately taking care of their asthma, not going to the ED. So instead of going to the emergency room because they needed a refill, they already had their plan, they knew what to do, and they would call. Beyond that, any physician covering for me also knew that. And so it created a level of communication that prevented that person from going to the emergency room for something that could have been taken care of. And that's just an easy example of a direct cost. There's indirect costs because you may have people buy into the condition. You may target the barriers that are preventing them from having good control. And so I think there are multiple ways that we can lower that cost of chronic disease, but ultimately every touch point and every chance that we can take to understand that patient better is going to lower the cost. And so whether it's through the use of peers in the presence of a physician, I mean, that's the other just caveat is it's a filtered way of dividing information on the internet and everything that's out there, and to just say, here, here's the current guidelines. You may not need this test every year. This is why. So I think there's other ways that we can control costs by really sharing accurate information with patients and addressing some of that.
Does anyone on the panel have experience with using volunteers as sort of the intermediary to go into the doctor's office and be that person, as sort of the second eye and ear, and sort of, as Daniel was explaining some of his role and what Dr. Jervis was talking about? Do people use volunteers at all? That was a question from our audience. Doesn't sound like. I'm going to take that as a no. All right.
I mean, I feel like all the work that I do online, connecting with other patients,
Sure.
is volunteer.
Yeah, absolutely. Yeah, I just want to make one comment before we go on to the next question. I just think that, and this is for everyone who's listening in too, I think if we all really understood, or we're beginning to, as we're hearing all these really astute real life experiences and comments, we should be all doing this in every disease that we possibly can. I think we're just not leveraging the social power enough to, and it'll impact in a very holistic or altruistic manner people's lives, like Julie's. You heard her story, but it'll also impact the economics too. So I really want to figure out how to do it. I know I have the advantage of being at a big virtual care provider, but I'm going to try to figure out how to get like mentors virtually connected with other patients. So you'll hear more about that maybe down the road in emails from me. But we've got to do something. We've got to do better. And you're hearing Cleveland Clinic and some of these organizations, Utah, doing it, and it's helping people. So those of you in the audience, figure a way to bring it to your organization. Let's talk about what makes a good mentor. It can't be just willing to show up on my panels. There has to be something else to it. So, Ramiro, I'm going to bring you in. Dr. Jervis, what would you, if I gave you an unlimited budget, because I'm sure that's at Langone, that's what they do. Tell me what would you look for in sort of a mentor support your practice?
Well, it's probably similar to what we look for in our community health workers. It's someone who's, we select them based on their emotional intelligence, someone who could easily engage patients and people, very personable. And I think they have to be culturally concordant with the population they're serving. So in our situation in Sunset Park, for example, that means someone who's bilingual, who speaks Spanish, who ideally lives within the community. So it's a person who's much more, have an easier time connecting with our patient population. Ideally, they also have some of the diseases that that the patients are struggling with too. So if someone already knows how to check their finger sticks and how the issues with checking their sugars and logging them in, is going to be able to better connect with the patient with poorly controlled diabetes. There are programs out there that certify peers or CHWs in educating patients with chronic disease management. I think some certification would be really ideal for a program like this.
Is there any one or two that stick out as being like the Ivy Leagues, the certifications that you could share with everyone, or no?
Nothing that off the top of my head right now. We actually train our own CHWs with regarding chronic diseases, and so we do it internally. So but there are certification programs out there.
Send them all to New York.
Over to NYU.
Okay, all right.
Mm-hmm.
I want to build upon that, Daniel. I'm going to bring you in. I would love for you, because I know I saw you nodding your head. I know you agree with a lot of what Dr. Jervis just said. Could you jump in and take what Dr. Jervis just said and provide us that example? You had an example you told me about Keith and how what Dr. Jervis just said and what you did for Keith and how that kind of connected. So let's give a real life example of what makes a good peer mentor. Go ahead.
First, I'm super excited about what Dr. Jarvis was saying. That is exactly that would be my ideal everywhere. But yes, one of the things that as Julie was saying, I'm a community volunteer, because with my podcast, with my HIV positive page, the information's out there. So one of the great things is that friends around me or people that know me know that I'm always available to give out information. There's, and we'll name him Keith. Keith was newly diagnosed. He's in his early 20s. He's a friend of a friend, and obviously very confused, very scared. Again, cultural religious and different backgrounds that stopped him from being open with his family. So who does he go to? He confides in his friend. He is referred over to me via text. We start a text relationship just to ease him and spoon feed him the diagnosis, slowly and steadily, just talking through the process of being newly diagnosed. We then moved into a Facebook friendship. We were connected on Facebook. We were able to message each other, connect. He was able to look at my page and see what I do on a daily basis. I'm very open about when I feel bad, so people know my dailies. And eventually he got motivated enough that being diagnosed in the last, I would say, 3 months, he approached his human resources department at his company to start a health empowerment workshops at work. And this February, coming up soon, I will be joining them in their first HIV education program for this company. And it's a small boutique hotel chain here in LA. So I'm very excited that we're going to start getting that word out to people that normally would not access that information because it's not in the first degree for them. But now that he works there, we're implementing this. And even more excited is that we're doing this on a quarterly basis. So for this first year, we've already set out a quarterly plan to go in and not just address HIV, but other related health issues and self-empowerment that comes along with it.
Wow. So, I mean, just to summarize that, because it's a take right on what Dr. Jervis set the stage for. You were able to relate to him. He related to you. So you inspired him not to isolate himself. I'm sure you didn't mention it specifically, but I'm sure like the mental burden of his disease diagnosis, right, which affects probably everything.
Definitely. I think, as I said earlier, it's that 35 years HIV has been around, and yet every time somebody's diagnosed, they immediately go into that black hole. And some of us need to have windows into that hole so we can pull them out. And volunteers, community liaisons, advocates, activists, we're all there taking a peek in the window every now and then going, oh, there's somebody else. I need to help them out, which is something that we talked about, what I like to call a tailor stylist appointment. And if anybody uses that term, I want credit on it. But it's kind of like the nurse coming in, and it's a 3-part program that I look at. The nurse comes in like a new suit, and it's asking you what your needs are, what you're going for, what your daily is. So she gets you set up. Then the doctor comes in and measures everything for you, tailors everything for you, the medicines, the appointments, when you're coming back, what do you need to do? And then the advocates or the mentors, we come behind and we help you stylize it all. The socks, the tie, the hat. So, and then we can come back as a group and go, wow, look at what we did. We didn't just make somebody better. We empowered them, and now they're advocates, and they can go on and spread the word.
So I'm looking at the clock. We got 7 minutes left. Now we actually got, all of a sudden, our audience, which is a little bit quiet. Now their questions are coming in. I'm going to try to get to these questions. There's really good ones. I see yours, George, Eugene, Catherine. I see them coming in. I've got 1 or 2 other sort of follow-ups, and then we'll get to the audience questions with the time we have remaining. Julie Croner, I want you to come in with your mentor hat now. You've been talking a lot sort of as the patient. We're talking about what makes a good mentor, and I know you had some specific thoughts on, what the mentor's role is as it relates to preparing for that doctor's appointment. So I wonder if you could expand upon it for the group.
Yeah, absolutely. Just like Dr. Jervis and Daniel, you both mentioned being prepared for doctor's appointments and writing down your notes. I know my own doctors are like, I come in with my binder full of questions and they're like, oh boy, like they roll my eyes. Okay, cancel my next appointment. But I think something that's really important and something that was instilled in me from other peers that I talked to before I became my own, peer mentor, was just empowering yourself to realize that, yes, you have to take control of your own situation, and you can't just rely on what the doctor is saying. It has to be a collaboration, and you need to speak up and tell them exactly what you want in life. So make sure you and your doctor are on the same page in terms of what you want. What is your definition of quality of life? So going back to my own experience, the doctor who said walk on crutches for 10 years until your knee collapsed, that was not the definition of the quality of life that I wanted. So having those conversations and really creating that trust with your doctor is so important. So someone who can help instill that in another patient, I think, is extremely important.
And Dr. Julie Day, what are you looking for in good mentors from your perspective on the physician side?
I think what she just mentioned was really critical in terms of what are your overarching life goals? What is it that you're wanting to be able to accomplish or live toward? And then being able to sit down with that patient and understand what those goals are, but then prioritize the visit. Obviously, there's a lot of time pressure in provider visits. And I think making sure that we understand their big goals and then being able to prioritize the issues around those goals is really critical.
Right. And I promise I did not ask this question. This comes from Dr. Eugene Spiritus, but it sounds like I kind of hit it in there. But has anyone tried video conferencing shared meetings so the patients don't have to come into the office?
So we are doing virtual shared appointments and really looking, and you have to meet the patient halfway, and meeting them at their home or in their workplace can certainly bridge some of those communication opportunities. And so that is our emphasis for this year, and we have our first chronic disease virtual appointment starting up. I think part of it is understanding the dynamic difference, because when someone's sitting next to you, there's always a difference in how you relate and how you interact. And so certainly, I think there'll be something to learn about how media may change that interaction. But absolutely, again, I think it's about the touches and getting people in. So if we can do that, that's something that we'll be doing a lot more of.
Yeah, I mean, hey, we're interacting pretty well right now, right? In our little group session. So I'm going to ask everyone to put sort of their CEO or strategy hat on. I don't know if we'll be able to get this question nailed, but it's such an interesting one. I want to make sure we throw it out there in the few minutes we have left. Are there ways for these peer-based programs, whatever format they may be, to plug into a value-based care design? Does anyone have a reply for that or response for that?
I'll just weigh in, because I think across the country we're trying in every aspect to move towards value-based care. But I think this absolutely supports, we've talked about the value of peers in terms of, I think asthma plans were mentioned, preventing hospitalizations, preventing ED visits. That's really what we're looking at in terms of a value-based dynamic, is making helping people utilize those resources that are available to them and the resources that are needed at the appropriate time. So I see this absolutely fitting into a value-based scenario.
I mean, so I agree, and just to the person that asked this, I believe, like, if you just take diabetes, and if we could all agree for a moment, if your A1C scores go down, you're less likely to be a high utilizer. You still may be, but you're less likely to be a high utilizer of services. I think whether it be shared appointments or one-on-one mentoring, if you could impact that A1C score. I know there was a pilot done, and I'm sure Cleveland Clinic has tons of data on this, but I know Langone did one a while back, and it absolutely did impact A1C scores in a positive way, and that's going to only turn to value. And if it's a shared savings model, it's going to result in more money in the account for both sides of the paradigm. It's one of the reasons I'm actually, want to push something using virtual to do it with my, my day job hat on, because I just think there's so much opportunity to fit into a value-based care design, because it's not terribly high cost relative to the alternatives. So I know that wasn't asked to me specifically, but I'll answer it anyway. All right, so we're at the top of the hour. By now you've received an email asking for your feedback on this session. We could do this again in a month or two if everyone screams that this was really valuable. For those of you whose questions we didn't get to, I could see maybe one or two I didn't get to. I could shoot them out to our panelists afterwards and see if I could get some written responses, and if so, forward them on to you. To the six of you, thank you so much. I know this was a lot of time, not just the 60 minutes, but the time you took with me and Sherry to prep for this, so I really appreciate it. And for all of you who took the time from your busy days and tolerated all the emails promoting this thing, thanks so much for joining us. Within the next day, I will have a recording for this. We'll put up on the website. We'll shoot out an email to let you guys know if you missed something. Great job, everyone. I really appreciate it. Applaud you all. Have a great day.
You too.
I'll be in touch. Take care.
Thank you.